Hello everyone, my name is Tom Ruffin. I am a pediatric emergency medicine physician at Arnold Palmer Hospital for Children at Orlando Health in Orlando, Florida. Today I'm going to go through our study, Intranasal Fentanyl to Reduce Pain and Improve Oral Intake in Children with Infectious Mouth Lesions. Painful infectious mouth conditions such as herpes angina, hand, foot, and mouth disease, and herpetic gingiva stomatitis are a common presentation to the children's emergency department. They are self-limited, but can cause pain, dehydration, and hospitalization in young children. Treatment for these conditions is generally supportive and directed towards pain relief from ulcerative lesions, thus facilitating oral intake and preventing dehydration. Oral therapy at home and on arrival to the children's ED is very limited and often refused. Previous studies have demonstrated the ineffectiveness of topical therapies such as viscous lidocaine in the management of these painful oral lesions. The AAP supports the CDC recommendation that oral rehydration therapy is preferred over parenteral rehydration in the management of mild to moderate dehydration in children. Currently, the AAP recommends aggressive oral rehydration therapy over 4 hours and defines successful oral rehydration therapy as 0.4 cc's per kilogram per minute, which in the emergency department setting may be an unrealistic goal. Further studies found that expert clinical opinions perceived fluid intake greater than 9 milliliters per kilogram as adequate, less than 5 milliliters per kilogram as inadequate, and that a difference of 4 milliliters per kilogram during oral rehydration therapy is clinically important. Determining a child's degree of dehydration can be a difficult task. Previous studies have established a direct correlation between end-tidal carbon dioxide via nasal capnography and the degree of dehydration. Currently, a standard practice for painful infectious mouth conditions at our institution includes the use of an oral analgesic, acetaminophen with hydrocodone. This is often refused or immediately spit back up. Several studies have demonstrated the safety and effectiveness of intranasal fentanyl in treating pain in children with traumatic injuries, but there is limited data examining intranasal fentanyl use for painful infectious mouth conditions. This study evaluated the efficacy of intranasal fentanyl compared to a commonly used oral acetaminophen hydrocodone formulation used at our institution for the treatment of children with painful infectious mouth lesions. The study was a prospective, non-blinded, randomized controlled trial conducted in an emergency department in an urban, academic, tertiary care children's hospital. We enrolled children 6 months to 18 years of age with painful infectious mouth lesions and poor oral intake. Children were randomized to receive either intranasal fentanyl at a dose of 1.5 micrograms per kilogram or oral acetaminophen with hydrocodone at a dose of 0.15 milligrams per kilogram. The primary outcome was volume of fluid intake per body weight 60 minutes after analgesic administration. Secondary outcomes included objective hydration status measured by levels of expired end-tidal carbon dioxide, pain scores using a validated visual assessment scale, where 1 was no pain and 10 was the worst pain, a parental perception of hydration score, where 1 was well hydrated and 4 was very dehydrated, admission rate, and an overall parental satisfaction score, where 1 was the worst and 7 was the best. A power analysis showed that 34 patients were required to achieve an 81% power to detect a difference of 4 milliliters per kilogram with an alpha of 0.05. Of the 34 patients enrolled, 17 were randomized to receive intranasal fentanyl and 17 to receive oral acetaminophen with hydrocodone. The demographics in both groups were similar in age, weight, gender, and race. This table is a comparison of intranasal fentanyl to our institution's standard of care, oral acetaminophen with hydrocodone. There were no significant differences in baseline end-tidal carbon dioxide, parental perception of pain, or hydration status. As you can see, both groups achieved adequate hydration. The oral fluid intake at 60 minutes was 20 milliliters per kilogram for the intranasal fentanyl group versus 18 milliliters per kilogram for the oral acetaminophen with hydrocodone group. The levels of end-tidal carbon dioxide at 60 minutes were 36 versus 35 millimeters of mercury, respectively. The pain scores at 15 and 30 minutes were 1.7 versus 2.9 and 0.6 versus 1.6. The parental perceptions of pain and hydration status at 60 minutes were 2.2 versus 2.4 and 1.7 versus 1.5. The overall parental satisfaction was 6.4 for intranasal fentanyl versus 6.5 for the oral acetaminophen with hydrocodone. The admission rate was 0% in the intranasal fentanyl group versus 12% in the oral acetaminophen with hydrocodone group. There were no significant adverse events such as respiratory, cardiac, or CNS depression in either group. In conclusion, intranasal fentanyl was as safe and as effective as oral acetaminophen with hydrocodone in reducing pain and improving hydration status in children with painful infectious mouth lesions and poor oral intake.